This conference will now be recorded.
Yeah, good afternoon all. Can I start the class or should I wait for some more time?
Start, sir.
Yeah, okay. Today's topic is osteoarthritis. So osteoarthritis, this may be given as a 4 marks question or it may be given as a short case for you in the exam. So just see the slides so that you can remember something. Osteoarthritis is a degenerative slide. The etiology is multifactorial, but it is due to mainly due to the wear and tear of the joints as one ages. There are two types, primary and secondary. So primary osteoarthritis, this is mainly due to the old age. This occurs in a joint de novo. It is mainly seen in the weight-bearing joints, which are knee and the hip. So in a generalized variety, the trapeziometacarpal joint of the thumb, it is the most commonly affected joint in the hand. So this trapeziometacarpal joint of the thumb is a saddle joint because you can move it in all planes. And coming to secondary, there will be some underlying pathology which causes degeneration many years later. It may occur at any age after adolescence, and it most commonly hip joint is involved in secondary OA. So predisposing factors for secondary osteoarthritis are congenital maldevelopment of a joint, irregularity of the joint surfaces from previous trauma, previous disease producing a damaged articular surface. Whenever the articular surface is damaged, the bone gets directly in contact with the bone in the joint. So it may lead to secondary osteoarthritis or any internal derangement of the knee, like any injury to the cruciate ligaments in a knee or to meniscus or a loose body. And malalignment, it may be either genu varum, bilateral genu varum or bilateral genu valgum, bow legs and knock knees, obesity and excess weight. So causes of secondary OA of hip, the main cause is avascular necrosis of the joint, which may be due to the most common causes idiopathic and post-traumatic alcoholism, postpartum osteonecrosis, which occurs immediate after pregnancy, chronic liver failure, patients on steroids, patient on dialysis, sickle cell anemia, and the next causes are coxa vara. Any vara is decrease in the angle. So coxa vara is the angle decrease between the head and neck and the axis connecting the neck of the femur and the shaft of the femur. It will be almost 90 degrees or so. So the femur will be like what we call, it may look like a stick. So developmental dysplasia of hip and old septic arthritis of the hip followed sequelae of any infections, malunited fractures and fractures of acetabulum. So coming to the pathology, it is a degenerative condition, mainly affects the articular cartilage. So the first change observed histopathologically is there will be an increase in the water content and depletion of proteoglycans from the cartilage matrix. And repeated weight bearing on such a type of cartilage, it results in fibrillation. So what is fibrillation? Here in this slide you can see the articular surface should usually be like an even surface, but as you can see there are some fissures and fibrillation seen in the articular cartilage. And here the same thing you can see here. If there is any injury to the articular cartilage and due to prolonged weight bearing, there will be development of cracks which are fissures, and finally they develop into fibrillation. These are the flakings which will be released to the joint, which may cause some inflammatory reaction in the joint. So a brief anatomy of the articular cartilage. So articular cartilage and the below one is bone. So this is the tire mark, means it separate the line which is separating cartilage and the bone. So cartilage, it consists of 3 layers: superficial, tangential. Here the fibers are arranged tangentially to the surface. So this is the superficial tangential zone, which comprises 10 to 20%. So middle part, they will be arranged in any direction, and the deep things, they will be arranged perpendicular. So this is the structure of articular surface made up of 3 layers, and below it is the bone, calcified bone, subchondral bone, and cancellous bone. So the cartilage gets separated by the grinding mechanism at work at the points of contact between the opposing surfaces until eventually the underlying bone is exposed. So if the cartilage is completely damaged, the bone will be exposed. The that process is what we call as hibernation. With further rubbing, the subchondral bone becomes hard and glossy. It's also called as hibernated. So as you can see in this picture, this is the articular cartilage, white thing. Usually it should be seen, but here the cartilage is completely gone and the bone has become eroded and hard. This is called hibernation. So morphology, in the first diagram you can see the fibrillation of articular cartilage already described. So the second diagram, it is the cross section of a femoral head where you can see severe osteoarthritis with hibernation of the bone because there is no cartilage here. And the second thing, this is called a subchondral cyst. This is due to fibrillations and fissure extending into the bone, leading to the softening of the bone. So you can see a subchondral cyst over here. And the third thing, this is the normal articular cartilage seen in a joint. And meanwhile, the bone at the margins, it hypertrophies and forms osteophytes. So in this picture, you can see this. The blue one is the normal articular cartilage, which is thinned. So which leads to development of fibrillation and finally subchondral cysts. Sometimes there will be a subchondral sclerosis in the bone, and the bony extensions which are formed in the joint, these are called as osteophytes. So what are the things you can see on an X-ray? The first thing you see is joint space narrowing. Okay, the joint space here you can see it very clearly, but in this picture the joint space is narrowed. This is an indication of osteoarthritis when you see an X-ray or a radiograph. And with the extensions of the bone which occur near the joint, these are called as osteophytes. Then there will be remodeling of the bone contour. There will be loss of cartilage and subchondral sclerosis, subchondral cysts, and there might be an osteochondral body which is called as a loose body. So this loose flakes of cartilage, they incite synovial inflammation leading to the deformity and stiffness of the joint. Usually only one compartment is affected more than the other. For example, in the knee joint, medial compartment is more involved than the lateral compartment. So it leads to a varus deformity, which is also called as bow legs. So another picture demonstrating the features seen in osteoarthritis. There is a bone cyst here. The capsule is thickened. There will be synovial inflammation due to the flakes of cartilage released into the synovial fluid. Cartilage fibrillation, meniscal degeneration, osteophytes formation, and subchondral bone thickening and bone marrow lesions. These are not indicative of osteoarthritis but may be seen. So this disease occurs in elderly people, mostly in the major joints of lower limb, frequently bilaterally. And for Indians or for Asian people, the knee is the most commonly involved joint, but in Western population, hip joint is most commonly involved. So what are the symptoms? Pain is the earliest symptom, and it occurs intermittently in the beginning, but it becomes constant over the months or years. Initially, it's a dull pain, and sometimes it comes on starting an activity, but later it remains completely and it comes after the activity. So crepitus, the sound which can be heard when the joint moves, it can be felt in every patient having osteoarthritis. Swelling is usually a late feature. Stiffness will be there due to the synovitis and due to the pain and okay, sorry. And the other symptoms will be the patient might be feeling might be having a feeling of instability. It is due to the osteochondral bodies, which are called as loose bodies. These are due to the cartilaginous flakes which are released, and sometimes the osteophyte gets separated and becomes a loose body. This loose body comes in between the both joint surfaces. It may erode the joint more, or it may cause locking of the knee. So on examination, these to be told in the exam: tenderness of the joint, crepitus, and if you feel any osteophytes from the palpate on palpation, you should be able to tell the irregular osteophytes palpated. And deformity, usually in knee it will be varus, but in hip it will be flexion, adduction, external rotation. So effusion, it's very rare. The terminal limitation of the joint movement will be seen, and subluxation, it's usually in the severe cases of osteoarthritis. There will be quadriceps femoris wasting. So next, how do you manage this case? First, you need to go for investigations. The first thing you need to write down is a radiograph. So you need to take a radiograph of knee joint, both anteroposterior view and lateral view. Anteroposterior view is most commonly taken in weight bearing position. So what are the features seen in a case of osteoarthritis? First thing is a sorry, first thing is a reduced joint space. Then the bony extensions, what we see are the osteophytes. There will be a subchondral sclerosis. Okay, sometimes there will be subchondral cyst. This here you can see the subchondral cyst. Okay, the round thing which you see here is a subchondral cyst. Okay, and the narrowed joint space, and in severe cases you can see various deformities of the knee. So the 6 things which are seen are reduced joint space, osteophytes, subchondral cysts, subchondral sclerosis, and deformity of the knee, most commonly varus deformity in a case of severe osteoarthritis of knee, and loose bodies might also be seen. So how do you classify osteoarthritis of knee? Depending on the Kellgren and Lawrence system, you can simply call it KL system. So in this, there are 4 grades. Grade 1, it's almost normal. Grade 2, there will be a doubtful osteoarthritis. There will be minimal osteophyte formation, but not sure. In the third thing, there will be a definite osteophyte formation with a normal joint space. In moderate, there will be moderate joint space reduction. But in the case of severe thing, your joint space is completely reduced, and you can see subchondral sclerosis also. Sclerosis is thickening of the bone. So according to Albach system, another classification, knee joint osteoarthritis is classified as 5 grades. So the grade 1 is joint space narrowing less than 3 mm. Grade 2 is joint space obliteration. Grade 3 is after the joint space gets obliterated, the bone gets in contact with one another, which causes attrition. So grade 1 is just narrowing. Grade 2 is complete loss of the joint space. Grade 3 is minor bone attrition, moderate bone attrition, severe bone attrition. 0 to 5, 5 to 10, and greater than 10 mm, like greater than 1 centimeter. So other investigations, just to rule out the other pathologies like serological test and ESR, serum uric acid to rule out gout, and arthroscopy is rarely done if only in case of a persistent loose body or a frayed meniscus. Principles of treatment: the disease once started, it doesn't stop, it progresses gradually. So we need to take the following efforts: either to delay the occurrence of the disease, or to stall the progress of disease and relieve symptoms, or to rehabilitate the patient with or without surgeries if the disabilities can be partially or completely elevated. So coming to the non-surgical management, first, whenever a patient comes with pain, you need to decrease his pain, so you need to give him NSAIDs. Then chondroprotective agents like glucosamine and chondroitin sulfate should be given. Recently, viscosupplementation, which is the hyaluronic acid or sodium hyaluron, it is injected in the joint 3 to 5 times, but it should be done under aseptic precautions, not to give infection to the knee joint. And local application of a counter irritant gel, which is a methyl salicylate gel or a diclofenac gel, to be given. So the most common things we do are lifestyle changes. We tell them not to climb stairs, avoid squatting and sitting cross-legged, and ask them to reduce weight and avoid excessive walking and running. Walking can be advised at least for half an hour a day, but ask them to avoid excessive walking and running. So, and the physiotherapy, mainly range of motion exercises and quadriceps exercises, and IFT, SWD, these are all done to relieve the pain. And intra-articular steroids, these should be given carefully because steroid is a double-edged sword. It may decrease the inflammation, but in the same way, it may cause infection to the knee joint. So it should be carefully given. If you are planning to operate on a case of knee, better avoid steroids. So coming to the surgical management, these are the surgical things done in orthopedics for knee osteoarthritis: arthroscopy, osteotomy, hip resurfacing, arthroplasty, and orthodesis. I'll come in detail about everything. Arthroscopy. Scope means you need to look it through a camera and do whatever you want to do, like debridement and lavage. So you just clean off the debris in the knee joint, or you can do an autologous chondrocyte implantation. This is a recent technique for development of cartilage inside the knee, but it should be done in an young patient only. And osteochondral autograft, almost the same as ACI, which should be done in an young person. So just a pictorial representation. This cannula won't be there usually. We keep an arthroscope through which we will be looking, and through another instrument you need to operate everything. So osteotomy is cutting of a bone. Osteo is bone, otomy is opening. So you need to cut a part of the bone so that you relieve some symptoms. So in case of hip, these are two: either you do it in the femur or you do it in the pelvis. So proximal femoral osteotomy or pelvis osteotomy. For example, just for your understanding purpose, I am just giving you, we remove a part of the bone and you fix it with a plate so that the weight bearing axis is changed. Here in this diagram, the weight bearing axis falls over here. So this part is more degenerated. When you shift the axis, it will be changed to this part. So the patient will have decreased symptoms due to the change of the weight bearing axis. Okay, this is called a valgus osteotomy. This is a varus osteotomy, and this is what we call as cherry pelvic osteotomy, where you do it in a pelvic bone. Here you are doing it in femur. So in case of knee, there are three types of osteotomies. High tibial osteotomy. This is recently done more in young patients to avoid replacements. And proximal fibular osteotomy, it is not recommended as of now. And distal femoral osteotomy, it may be done in case of deformities. So this is what we call as a high tibial osteotomy. We need to just change the axis. Here you can see the joint space has increased compared to the previous picture. This is what we call as a proximal fibular osteotomy. We remove a part of fibula so that the axis changes, so the space might be a little increased on the medial side. And coming to the hip resurfacing, just we need to replace the part of the hip which is eroded. So we just remove the head and apply an implant which is called hip resurfacing, usually done in younger patients like 40s. And the last thing is arthroplasty. Arthro means joint, plasty means change. So you need to change the complete joint. In case of hip, we call it as total hip replacement, and in case of a knee, you call it as unicondylar knee replacement. You have two types. One is unicondylar and the second one is total knee replacement. So in case of hip replacement, as you can see, you need to remove the part of the femur here and a part of the acetabulum over here. You are keeping an acetabular component and a plastic liner inside, and this is called a femoral stem, for which the femoral head can be attached depending on the size of our femoral head. So THR is done in such a way. THR is a total hip replacement, and this is knee replacement. This is unicondylar. You just change the medial side only. Okay, whatever is eroded, this should be done only if you have, these are the two structures, this is ACL and this one is the PCL. This should be intact for us to have a unicondylar knee replacement, and the lateral compartment should be free from any degeneration. And this is the total knee replacement, where you remove everything from here to here and replace it with an implant. Okay, and another diagram just to clear for you, make it clear for you. The femur part is removed and we keep a femoral component, and the tibial cut is done, you keep a tibial component, and in between there will be a plastic spacer for movements. So arthrodesis, arthro is a joint, desis is fusion. So to decrease the pain, you can fuse the joint, but you will not have any movement in the joint. So for hip, it is fixed in 20 to 30 degrees of flexion, adduction, and 5 degrees of external rotation. And in case of knee, you need to have 5 to 8 degrees of valgus. Usually the knee is fixed in a little valgus, external rotation, and flexion. So arthrodesis, we open the joint and you debride everything, and you keep a screw, or at least you can keep a plate so that it will not move and it gets fused. In the case of knee, the following things can be used. Fixator, which can be used for knee arthrodesis. You need to open the joint, nibble everything in the articular area, and apply an elixir, or you can use plates, or you can use a knee arthrodesis nail. Okay, thank you. Any doubts?
No, sir.
Can I end the class? Yeah.